Good afternoon, everybody, and welcome to our next Safer Prescribing series webinar funded by the Michigan Department of Health and Human Services. Today, we will be discussing stimulants, prescribing risks, and management. My name is Michael Smith. I'm an associate professor here at the University of Michigan College of Pharmacy. And today we have a wonderful speaker that you'll hear from that I will introduce shortly. Next slide. There are no financial disclosures for this presentation. Next slide. On the screen, you will see the learning objectives for today's session. We will hear from our speaker and have time for a question and answer at the end of the session. Please put any questions in the Q&A in the Zoom controls at any time during the session. Next slide. We are offering one AMA PRA Category 1 credit for free for attending this session. You will find information for claiming CME at the end of the session and in the follow-up email you'll receive later today. Next slide. And I'm happy to introduce our speaker. Allison Forbes is a psychiatric provider practicing out of a federally qualified health center in northern Michigan. Prior to this, she has worked in inpatient, partial hospitalization, and hospital psychiatry consult service settings. She currently sees patients across the lifespan, with about half of her panel being pediatrics. She also partners with addiction medicine clinics to treat psychiatric conditions co-occurring with substance use disorders. And within psychiatry, she holds specialty certification in ADHD diagnosis and treatment, leading to inclusion of her in this webinar series. I'll hand it over to Allison to begin our presentation.
Thank you, Mike. Like Mike said, my name is Allison Forbes. I'm super happy to be here talking with you guys today. Treatment of ADHD is really a special interest of mine, and so I'm excited to kind of share some tips and tricks. Next slide. So today we are going to be looking briefly into the background as far as ADHD in the context of stimulant prescription, and kind of talk about the risks and benefits of treatment. We'll talk on guidelines, but really we're going to be focusing on kind of the stimulants rather than treatment guidelines in general. My goal is today you leave with some practical knowledge that you'll be able to kind of take and immediately be able to put into practice. And next slide. Next slide. Thank you. So a little introduction. I think a lot of us have probably seen the impact social media has had as far as patient interactions. As of late, ADHD, neurodivergence, things along those lines has been a trending topic, specifically on TikTok, which is fun. With this, there's been visible changes in prescription habits. So there's been a pretty significant spike in stimulant prescriptions. So DEA recently put out a report. So about 60% increase from 2012 to 2022, which is pretty intense. Along with this, another interesting layer is that under the age of 40, we're seeing there's a rise in starting prescriptions with telehealth visits. Which can be secondary to kind of COVID and how that came along, but there has been a rise in online evaluations and treatments where all of it is virtual. The co-prescription of stimulants with other controlled substances is kind of another layer of complication, and it's not to necessarily say that patients don't meet the necessity of multiple controlled substances. It's more of raising the question of kind of that cost versus benefit. And especially since, we don't have a lot of data as far as, long-term effects of co-prescription of multiple different controlled substances. And as far as looking at kind of what those controlled substances are, most commonly prescribed controlled substance with a stimulant is a benzodiazepine, which is, interesting that you would be using a CNS depressant along with a CNS stimulant. Second to that would be opiates, although that has significantly gone down. There's been about a 10% decrease in that same 2012 to 2022 study. Next slide. So top prescribers, I think this gives a good visual as far as kind of trends across specialties. So for the purpose of this, nurse practitioner has been kind of taken out. So this is nurse practitioners, including family med, internal med, peds. So we see the largest spike in prescription practices with nurse practitioners. As far as pediatric psychiatry, that's held relatively stable. And then there has been somewhat of an increase seen in family medicine physicians, however, not nearly the same as nurse practitioners. Next slide. All right, risk and benefits. Next slide. So stimulant treatment, there are pros and cons of every treatment that we could ever give a patient. Everything is that cost versus benefit, discussion with the patient, internal dialogue with yourself. So as far as benefits of treatment, individuals with ADHD, symptom-wise, we see more problems with impulsivity, more problems with emotional regulation. And so because of this, there's a lot of downstream effects. With ADHD, there is a pretty stark difference in mortality rates. So there was a 2-year study that looked at mortality of individuals with ADHD, of those who were treated and then who were not treated. So the individuals that were not treated, there was about 48.1 deaths per, I think it was 10,000. And that decreased to 39.1 after treatment. The most significant difference was in unnatural causes. So that kind of speaks to the impact of those impulsive behaviors. And so like the causes of death would commonly be, motor vehicle accidents or risky behavior, putting themselves in situations that generally you would not want people to be putting themselves in. And this is not just true in adults, we see it in children as well. So 18-year-olds with ADHD are 4 times more likely to die prematurely compared to their non-ADHD counterparts. And that's consistent even in our young kids. So 6-year-old, they're in the 6-year-old population of those with ADHD, they're about 2 times more likely to die prematurely. The improved occupational performance, I think, is probably one of the big things that bring people to us. Individuals with ADHD, they're more likely to be fired from a job. I think it's like 60% more likely or something along those lines. And they're more likely to quit. So we see about 3 times the rate of quitting a stable position in people with ADHD. And this also kind of stems into that personal realm. So we see more divorce because of likely similar concerns that they're having in the occupational setting. As far as mental health aspect, there's been studies that show that treatment of ADHD, since it improves that impulse control, we see lower risk of suicidal behaviors. Substance use is definitely a big area. So in people with ADHD, we see an earlier onset of substance use disorders. They have a reduced likelihood of reaching remission without treatment. And then those who do reach remission without ADHD treatment, it takes them longer to get there. Legal consequences, again, impulse control doesn't stop in one setting. So they're more likely to have license suspensions. So conviction rates of people treated versus not treated with ADHD. So untreated, about 76% to about 65%. So the criminal conviction rate is decreased with that improved regulation. Risks. Serotonin syndrome is on our list. We'll talk a little bit more kind of about the dynamics of that later on. Obviously, it's a stimulant, so we're going to see cardiovascular concerns with kind of the increased heart rate, blood pressure. Stimulants also carry risks of instigating mania and bipolar disorder and inducing psychosis. The risk of psychosis is generally more dose dependent, so higher risk at higher doses. Weight loss and impaired growth is especially problematic in our pediatric population. I haven't really had too many adult patients that have complained regarding weight loss. But it is something to keep in mind. And then the big one that I think that we all get concerned about is that the risk of diversion and abuse of stimulant medication. Next slide. Treatment guidelines. Go ahead. So I threw this in here just so that we've got kind of a basis. Again, we're not really going to go into the specifics of treatment. If you look at, so this particular algorithm is from Up to Date. And in adults, we separate out whether there's co-occurring conditions. So interestingly enough, stimulant treatment is considered first line, which I think very rarely happens in practice with a lot of our a lot of concerns with abuse, diversion. Am I making the right decision? I don't know too much about it. In adults, amphetamines are preferred as far as amphetamines versus methylphenidates. So data supports that amphetamines are more effective in kind of reducing those core symptoms of ADHD compared with methylphenidates, but we do also see more adverse events and side effects with amphetamines. Technically, recommendation is, beginning a stimulant. I would caveat that as ensure there's not any underlying co-conditions before jumping to stimulant therapy. And in adults, if you are in the primary care setting, I would strongly encourage completion of neuropsych testing to make sure that it is an accurate diagnosis that you're treating. You can also redo neuropsych testing after you begin treatment, which can really help speak to efficacy. Am I making things better? Are things getting worse? So it's good as far as ensuring we're making the right choice and then monitoring long-term success. Next slide. Individuals with co-occurring substance use concerns, there is a different treatment algorithm with that. Initial would be atomoxetine with that. In my practice, I don't necessarily avoid stimulants in these patients. From the data, we see improved outcomes as far as use disorders and remission rates with ADHD treatment. And so from that harm reduction approach, that benefit would outweigh the risk, but it necessitates increased monitoring. So not saying hand them a 30-day script of Adderall and have them be on their way. So for example, I have a patient that has a history of opioid use disorders and stimulant use disorders that I manage along with our addiction medicine team. So opioid use was pretty well managed with Suboxone, but still struggling with meth use. She had a verified history of ADHD. She had been on stimulants when she was in grade school, stopped, was not restarted. A lot of concerns from providers regarding her history. So we started her on Vyvanse, and with having her stable on Vyvanse, we were able to taper her off of all other psychotropics, including gabapentin. And so she has been in remission for both opioids and methamphetamines for about 4 years. For that particular patient, she was getting 1-week scripts at a time. And as she got more stable in sobriety, it went to 2 weeks and then 21 days and then finally to a month. And that kind of helps, one, with the support aspect of things, making sure that, you've got tabs on that patient. I can see if things are getting wonky. I can always get, random urine drug screens, which I do. I'll talk more about that a little bit later. All right, next slide. For pediatrics, so it's pretty similar to adults that stimulants are considered first-line treatment. But in kids, we go with methylphenidates first over amphetamines. In pediatrics, there's still that increased efficacy with amphetamines versus methylphenidates, but that increased side effects, adverse events seems to be more pronounced in pediatrics versus adults. So that's kind of why we go that methylphenidate route first. It is not recommended for children under the age of 6 to start stimulants, and unless severity of symptoms and they've trialed and failed a lot of different behavioral interventions and um, other management techniques. In the primary care setting, I would refer to psychiatry for these cases just to make sure that you're getting an adequate or an accurate diagnosis. They're being treated for the correct things rather than just throwing things at it. Next slide. All right, stimulants. Next slide. So amphetamines versus methylphenidates. So the goal of both is increasing dopamine levels. Both are working on preventing dopamine from going back into storage. So by inhibiting that reuptake, there's more available in the synapse for use. The one of the differences between amphetamines and methylphenidates is the amphetamines prevent the breakdown. So you're not going into storage, more is getting released from storage, and it's not getting broken down. The methylphenidates, we're blocking it from going into storage. There's some more released from storage, but that breakdown process holds steady. Next slide. Prescribing. Next slide. So like we had said, before starting, I would want to make sure you have an accurate diagnosis. For children, I generally recommend the Vanderbilt because you can get good data from teachers and parents, or Connors. There is a Connors that has a self-report portion for children who are developmentally at the age that they would be able to participate in that. In adults, I generally want to see neuropsych testing, or if they've got a comprehensive history where it matches up with that, started in childhood, previous trial of stimulants, they're transferring care from another psychiatric provider, I'm usually good with that. Follow the saying, start low, go slow. We always want to get baseline vitals. Possible EKG. So if they're followed by cardiology, I generally get cardiology clearance prior to starting anything. If they're within your organization, a lot of times it's just a message that I sent over to cardiology that's like, hey, this person established with me for care, looking at starting stimulant, any contraindications or concerns that you would have with this. If they've got a cardiac history, they're not following with cardiology, I would for sure get an EKG before starting anything and tell them if they start having any kind of symptoms or changes, I want them to stop and let me know. Choice of medication really depends on a lot of different factors, which we'll talk a little bit about more later. Switching. You don't need to cross taper between stimulants. It is an equal change. So you stop the one, you start the other. If you are going from a stimulant to a non-stimulant, I generally start the non-stimulant first and get that up to therapeutic dose and then stop the stimulant. So for example, start Strattera 40, increase to 80, hold steady there for a month, and then discontinue Concerta. I've just found that people generally do better having something already in effect rather than kind of stopping the stimulant and then they have this stark contrast and they feel like that Strattera is not really doing as much. Discontinuation, you do not need to taper. There is not withdrawal similar to like opioids or benzodiazepines that we get concerned about. Stopping abruptly can be uncomfortable for patients. So we can see in some detox clinics and whatnot, they will lovingly refer to a crack nap related to people when they're coming off of illicit stimulants. So they just get super tired. Um, Monitoring routine and random UDS. So as far as frequency of that, it would depend on the patient. It would depend on your resources. I prefer send out UDS because I get a quantitative level rather than just a positive or negative. They could be positive because they took one before they came in the office and they haven't taken it the rest of the month. So my preference is that I want to see that there's stable levels in there. Along with that, you can do a urine drug screen, a random urine drug screen, and a pill count. So the case example that I gave a little bit ago, the individual, when she was getting 1 week scripts, she could randomly get called in at any point. She had 72 hours to come in with her script for us to count it to make sure that that count was appropriate. And she was aware, and it almost puts that kind of accountability on there where it kind of takes that off the table. So I'm not trying to catch you. I'm being super upfront with you and telling you I can call you in at any time. Sometimes that just takes that temptation off the table. Appointment frequency depends on, stability, med changes, where they are in treatment. So let's say that I start somebody on a stimulant or I change to something different. I usually do a 1 month follow-up, make sure that we're steady at the dose. If we're good at the dose, then kind of push out from there. As far as, people who are stable Mabels, I will see them every 3 to 6 months, unless something comes up. Documentation, you want to document that you're checking MAPS. You have to send the controlled substance script, but it's always good to put that in the note, MAPS reviewed. I personally document that the patient is aware of potential for random and routine UDS, and I have a controlled substance agreement on file. So those are just good cover your butt moves. So if your stuff ever gets pulled, they can see, yep, they double checked everything. They were monitoring. They're golden. Next slide. So dosing. Dose increase has been relatively consistent across time. So generally we get about a 39 to 40% increase depending on the medication from starting dose to maintenance dose. The interesting thing is, regardless of the starting dose, we generally end within that same range. I still go the start low, go slow, because you never know when there's going to be a side effect or some kind of reaction. And I would prefer, if you're going to have some kind of adverse effect, it be on 5 milligrams of Adderall XR instead of 25. So that's a little tidbit. Still start low. The other thing that I wanted to cover is use of extended release versus immediate release. In my practice, I generally start with extended release. I very, very rarely am using immediate release. And if I am, it's mostly in children or it is an afternoon dose of medication. The immediate release medications, they come in quick, they leave quick, which means you're more apt to get that kind of dopamine rush, that vroom sensation, I've had them describe it as, compared to the extended release. And then the drop off, you're more likely to have kind of that irritability, sudden onset of symptoms returning, things along those lines. So I generally go for for extended release, first and foremost. Next slide. Methylphenidates. So we'll talk a little bit about each category individually. I'll get you some clinical pearls, and then we'll talk about some specific medications. So methylphenidates, we do see some effects as far as metabolism of other medications. So always check for interactions, or if appropriate, be monitoring levels. You may need to adjust your dose up and down. So a lot of times I tell patients that. So, hey, you're also on, you're also on Prozac. So this can kind of cause some changes as far as how your body breaks it down. If you notice that you feel different, or something is, you have a side effect come up, just give me a call. That may mean that we just kind of have to dial back a little bit. As far as the SSRIs in particular, so if we're kind of impacting that metabolism of it and working on some of those serotonin receptors, that is why we get that risk of serotonin syndrome. Use of alcohol with methylphenidates. So it's very interesting. So it's similar to cocaine and alcohol being cocaethylene. You see this ethylphenidate. And so the reason this matters is it inhibits the metabolism of methylphenidate, and you get higher plasma concentrations, and they are in effect for a longer period of time. So, if people are drinking while taking, their Concerta, in theory, that can kind of instigate some of that, the addiction pathways to kind of start. There's some data to support there's increased absorption with immediate release methylphenidates that are taken with food, however, not high fat food. And then the transdermal patches, the Daytrana patches, which are methylphenidates, you can see some irritation and skin lightening with those. It's not necessarily like, oh, if I see skin irritation, I'm going to stop it. It could be, hey, we need to make sure that we're really moving the patch to a different location farther than what you're doing. Next slide. Amphetamines. So atomoxetine, excuse me, prevents the norepinephrine release that's instigated by the amphetamines. So the stimulant may not work as well. However, this could be beneficial because you can kind of offset some of those cardiac side effects that we see. Absorption can be changed with amphetamines based on that stomach acidity. So the more acidic the stomach is, the less absorption of medication. So all of our people that are taking their Adderall with their coffee in the morning are not absorbing it the same way as they would without it. Inversely, so if you have people on antacids, they can have a drastic increase in absorption. So that's just another thing that I share with patients. It doesn't necessarily mean like, oh, you can't have that orange juice in the morning. It just means if you're going to do it, I would consistently do it rather than change your diet every morning and not necessarily have that predictable absorption level. Next slide. All right, so I think Jill's going to send out, I have these cheat sheets that I use. So basically, this kind of is a good guide as far as what are our options, what are some considerations. So as far as choosing stimulants, we said before, there's a lot of different factors that go into choices. So, have they been tried on anything before? Are there co-occurring conditions or health conditions? What's their insurance? And so it's not a one factor thing. You're not going to look at one specific, since they're over this age, should do this or whatnot. The main difference between a lot of these stimulant options essentially boils down to the mixture of immediate release and extended release in the delivery systems. So by that, methylphenidate, for example, there are a lot of different, there's Ritalin LA, there's Focalin, there's all the difference between a lot of these is how much is coming into effect, how quickly. So amphetamines, Adderall, XR is probably one of the most common stimulants that I see as far as transfers of care and whatnot. I think probably because the name is people know the name. So it releases its active metabolite in a way that mimics twice a day dosing. So how it would have been if you were using the immediate release and they took it that multiple times a day. So 50% of the medication is immediate, 50% extended release. In comparison, the Mydayis, I always get that wrong. It would mimic 3 times daily. So it's got like this triple bead capsule where you get 3 separate peaks. And so that kind of can go into our prescription choice. Do I need something to be in effect only for, 4 hours of the day? Do I need to worry about getting them through the school day? Is it a 12-hour shift that they need to make it through? Any individual with substance use disorder history, Vyvanse is usually my go-to. Reason being, Vyvanse, it can only be absorbed via the digestive tract. So you can't snort it, smoke it, inject it. They have to take it orally. That doesn't mean that it can't be abused because they still can, take a lot of it and get that rush, but it's less likely. Also, since Vyvanse is just extended release, they're less likely to get that quick onset that we see with the immediate release. There's dextroamphetamine, but I generally see, as far as prescription practices, people go with the mixed salts like Adderall. The one thing is the dextroamphetamine does have the patch, which is nice as far as delivery system goes, but insurance coverage is super crappy. The immediate release, there's options for both the mixed salt and dextroamphetamine. Again, I really only use it if I'm adding like an afternoon dose of a medication, and I don't routinely use immediate release amphetamine-based products in practice. Methylphenidates, we talked about how those are preferred in pediatrics, and you can kind of see the reason behind that. They've got a lot more formulations like chewables, solutions, patches, things along those lines. So if you have a patient that is on let's say that you have someone who's doing well functioning wise with methylphenidate in school, but those last few hours of the day, everything tanks off, and that's when they're getting all their write-ups and kicked out of class. You could change from the Ritalin LA, which is that 50-50, to Concerta, which would be more 25 to 30% immediate release with the remainder extended release. And that plateau may help kind of get you through the end of there, rather than adding a dose of that immediate release where you're kind of interrupting that school schedule. The difference between methylphenidate and dexmethylphenidate is a question that I get a lot. So essentially, dexmethylphenidate is the therapeutic component of methylphenidate, making it more potent. It's kind of similar to the effects or Prestige aspect of things. The Daytrana patch. So again, really, it's a nice delivery system. But they were having problems with production at one point, I believe, and I'm not sure how availability is currently. So if that was something you were looking at, I would research that. Jornay is also an interesting one. So Jornay, the way that it is formulated is that they take it at bedtime and it does not come into effect until morning. So kids where, morning behaviors are really difficult, and I need a medication kicking in before, an hour or two later, Jornay can be really a good option. But again, insurance coverage can be pretty critical. As far as considerations specific to any kind of coexisting health condition, tic disorders is technically listed on the package insert for methylphenidates as a contraindication. I don't necessarily have it as a hard stop. I find that you can generally, if you're at the point where you're doing a cost versus benefit, and the patient has tics, I think that the argument can be made that academic functioning, social functioning outweighs risk, and tic symptoms can be managed with other medications pretty effectively. ADHD is also super common in kids with epilepsy. As far as choice of medication, methylphenidates don't appear to increase the frequency of seizures in children, especially at the lower doses. But I would again point out that it can change the metabolism of some of those anticonvulsants. So you may need to coordinate with neurology on that. Sleep obviously can be impacted with stimulants. If you have someone who's having a lot of impacts in their sleep schedule, you can move towards the immediate release. Anecdotally, I see improved sleep in individuals with adequately treated ADHD. So I don't generally come across that too much unless they're taking their medications really late in the day, and then that's more of an education thing. Autism is also pretty common to see co-occurring, or ADHD is pretty common to see co-occurring with autism. Either methylphenidate or amphetamines can be beneficial. I would just make sure that there's not any, underlying congenital cardiac concerns or syndromal aspects that you would want to evaluate before starting. And then ODD, conduct disorder. If we look at guidelines on that, stimulants can be used, and frequently we see ADHD and ODD co-occurring together. I would defer to treatment guidelines for ODD rather than first jumping to a stimulant. However, if it is co-occurring with ADHD, it's completely rational to utilize a stimulant. Next slide. I think that's all I had for that. All right. So I think that this shouldn't necessarily be news, but I thought that I would include this. So finding the equivalent dose. So current medication, you take the current medication and divide it by our max dose. And then whatever the new max dose of the wanted medication is, multiply that. So Vyvanse max is 70, patient's on 40 right now. We want to get them to Concerta. So 40 divided by 70 would get us to about 30.9 of Concerta. And depending on the patient case, you could either round up or round down. Kids, I generally round down first versus rounding up. But that also can be a conversation with the parents as far as, what their comfortability is or severity of symptoms. Next slide. Questions?
Thanks for the great talk, Allison. I'm going to jump back in to help moderate some of the questions. I'm going to start off with one. When you're managing patients, how do you approach a patient who had a recent history of substance use disorders versus somebody who had a more remote history of one when you're thinking about either starting a stimulant or managing them that they're already on a stimulant?
So if a lot of times I go pretty transparent into it, like, and we'll kind of pose it to them. Hey, I'm sure that you're aware that, stimulants can be abused. Does that concern you at all as far as treatment is? Are you concerned as far as relapse or anything in those regards? And start the conversation with them, and kind of read their reaction. I found that there are some people, I equate it to like when my son does something wrong and I can see like the I'm trying to cover look on his face versus I've had patients be like, yeah, I do get nervous as far as, I've known people who have taken Adderall on the street, and I'll start the conversation. Well, what if we went with a super, super low dose of this? Or do you think you would want to hold off and we can keep talking about it? And getting their buy-in seems to help regardless of how remote that history is. I also am very upfront as far as, hey, you and I both know, like, you're still doing meth. it, it's not a secret. Um, I'm fine trying a stimulant, but we're going to get a drug screen every time you come in, which means I have to see that it's helping you. If it's not helping you, then I'm not treating you and we can't continue it. So it's kind of like including them in that you are an active participant in the outcome and you're an active participant in this discussion. And I seem to get better results as far as the end with that.
That's a really great point. So going back to urine drug screening, how do you handle a patient where they're on stimulant therapy and their urine drug screen now is positive for a non-prescribed substance that kind of comes out of nowhere for you?
So it that's always a slippery slope. The I am more concerned if you test negative for something that I'm prescribing than if you test positive for something I'm not. Regardless, we're having a conversation. If if they come in, and so I had this actually the other week. So I have a patient who had a recent relapse with alcohol. He is treated with Vyvanse, has been stable for quite some time. And his urine drug screen lit up like a Christmas tree. And he comes back, and I'm like, dude, what are you doing? And I almost bring it to them, not in a funny way, but in like a what? Come on, now what am I gonna do? Not look at this. Would you do it? Would you prescribe it? If I came in and was like, no, I swear I'm doing good. And if I come at them in a very relatable way, um, they understand that. I'm not against you, but I went to school for a long time to do this. And I'm not going to put it on the line for Joe Schmo on the corner so that you can, you know, keep doing cocaine while you get your Adderall script. Like that's just not how this works. Um, I'll tell them, hey, I'm not going to cut you off, but we like this is not good. This is not treating you. I'm not helping you if this keeps going. And their first initial instinct is fear that like I'm going to get cut off. And so that's where a lot of like that concealment comes in and can really impact the therapeutic relationship, by coming at them in not a punitive way, but a you get that this can't keep going. Like you got to work with me here. They tend to be more, I don't want to say amicable, more agreeable to interventions, more support coming in more frequently, things like that.
So what do you do in a situation where you don't necessarily have that therapeutic relationship yet with the patient? They're new to you, they're on a really high dose of a stimulant, you know, either unsafe or kind of towing that line of unsafe, but
Oh, it's the
they're
worst.
brand new, right? And so you can't
Yeah.
necessarily be like, listen, we've talked about this. How do you approach that
Yeah.
new patient?
So if it is a high, I've had a couple, had a couple that transferred care to me where their stimulant dose was like astronomical. It made me pause. um, And to those, I usually am pretty open as far as like you're asking for a cardiac event. I'm basically just training you for a cardiac event down the line. And they're like, well, this is the only thing that works. I'm like, well, if you have to take all of that, it doesn't work. And so kind of challenge their idea of work. It doesn't it medications don't work if you take 4 times the dose, then that medication doesn't work. You just figured out how to take a ridiculous amount. So by kind of coming at them with that, like maybe this isn't the medication for you then. Maybe it's not necessarily that the dose wasn't high enough. Maybe this isn't the medication. Maybe we should look at instead of, you doing a super high dose of this, maybe we need to do a lower stimulant dose and kind of augment with Strattera, or maybe you need a combination of different things. I've had some people who have used some very kind words towards me with that conversation. I have had some people who had no idea that their dose was that high. Um, like I had a guy a couple years ago who came in and he was on like 90 to 100 milligrams of Adderall all day. I'm like, dude, how do you like? There's no way you sleep. Just do
Yeah.
math. That's it. And so I basically showed him some like I will pull up stuff on my computer and show them like, hey, look at as the dose goes up, look at the rate of cardiac events. You already have a history. This is what with this we're just planning for this. We might as well just like figure that out. And again, including them in the information, rather me just saying like this is too high of a dose, including them in the conversation of the whys helps a lot. I'm not saying it works. There's some people that, like I said, have used kind words, and I just say, listen, you came here for my expertise. I'm just telling you, you know, my comfortability. I'm not prescribing you. I don't feel comfortable putting my license on that. If you had a different one, different provider that was cool with that, go for it. Go back. Live your life.
Really good points. Really good points. So thank you, Allison, for the talk. We're going to close it out. Jill, could you bring the slides back up? It was really wonderful. Lots of clinical pearls put in throughout this. I hope everybody enjoyed it as much as I did. Thank you again for speaking and our audience for joining. You'll be able to find the recording for the webinar on the website in a couple of weeks. We also encourage you to visit the Safer Prescribing Toolkit online, where you can find evidence-based information on stimulant prescribing, opioid prescribing, lots of good information there. Coming soon, we're going to have a specific toolkit for stimulants. So keep checking back for that site. There's always new information coming online. Next slide. And to claim CME, please scan the QR code that's currently on your screen. You'll also get these instructions in the follow-up email that you'll receive shortly. And the follow-up email will contain a survey about today's session. Please do try to complete that. We do read all of your survey responses and try to make updates and adjustments as we can, and we really greatly appreciate your feedback. Next slide. And this concludes our 2026 Safer Prescribing series. We look forward to hosting 3 more webinars in 2027 with topics and dates to be determined, but please look out for emails. And the best way to know when the new toolkit sections and upcoming webinars release is to subscribe to the newsletter. You can scan the QR code on the screen to find this information. Thank you so much for joining and have a great rest of your day.